Welcome back to the deep dive. We are back at the table, stacks of literature in front of us, and ready to tackle a subject that, we'll be honest, usually gets pushed to the back of the medical school curriculum.
It really does. It's often treated as this, the orphan chapter in a lot of pharmacology courses. It just sort of sits there at the back of the book waiting for someone to pay attention to it.
Exactly. I mean, we spend weeks, sometimes months, on bacteria, gram-positives, gram-negatives, anaerobes. We spend, it feels like a lifetime on viruses these days.
Oh, absolutely.
And then when we finally get to parasites, who takes up all the oxygen in the room? Malaria.
Always malaria. It's the undisputed heavyweight champion of infectious disease. And for good reason, obviously. The global impact is staggering.
Of course.
But, and this is the key point, treating malaria is a very specific discipline. If you only focus on malaria, you miss the vast, vast majority of the biological diversity in this kingdom.
That is exactly why we are benching the superstar today. No malaria. Today, our mission is to explore the other protozoa.
The ones that don't get the headlines.
Exactly. And looking at these sources, specifically Katsung's chapter on antiprotozoal drugs, and, of course, the dense molecular forest of Goodman and Gilman's chemotherapy of protozoal infections, this is not a small topic.
Yeah.
We are talking about a kingdom of organisms that is wildly diverse.
Wildly diverse is, I think, an understatement. We are spanning the entire spectrum here from the nuisance of a traveler's diarrhea all the way to diseases that are 100% fatal if you miss the diagnosis.
It's a huge range.
We're talking about entamoeba, giardia, trichomonas. Then you get into things like trypanosomes, leishmania. These aren't just bugs. They are complex, single-celled organisms with their own unique life stories.
And the thing that struck me while prepping for this, and this is really the central tension I want us to pull apart today, is the biology. When we treat bacteria, we are shooting at prokaryotes.
Right. They're aliens.
Total aliens. Their walls are different. Their ribosomes are different. It's relatively easy to find a target. It's like shooting a tank when you're driving a sedan.
That's a great analogy. Yeah, you can hit the tank treads because your car doesn't have treads. You can target the peptidoglycan cell wall because their cells don't have one.
Simple. But with protozoa,
They are eukaryotes.
they're us.
In a biological sense, yeah. They are us.
That's the scary part, isn't it?
Yeah.
They have a nucleus, they have organelles, they have mitochondria, or at least modified versions of them.
Yeah.
Their protein synthesis machinery, their DNA replication. It's all just uncomfortably similar to the patient we are trying to cure.
Which leads directly to the fundamental problem of all of antiprotozoal pharmacology, which is how do you kill a cell that looks and acts almost exactly like the host's cells without killing the host?
It's the ultimate friendly fire scenario in medicine.
Yeah.
And to navigate this minefield, we are pulling from those two heavyweights we mentioned. Katsung is giving us that great clinical scaffolding, the organization of what to give and when.
The how-to.
And then we're layering in Goodman and Gilman, which gives us that molecular reasoning and the deep, deep mechanistic why.
And as always, just a quick housekeeping note for everyone listening. This discussion is a conceptual map. It is an interpretive synthesis.
Right.
It is not a substitute for your textbooks. You still absolutely have to read the chapters. We're here to help you understand the story behind the data so that when you look at those drug tables, they actually make sense.
So with that said, let's hit the key takeaways up front.
Yeah.
If you have to bail in 10 minutes, which you shouldn't because this gets wild, what are the 4 pillars they need to take away from this?
Okay, pillar 1 is diversity is king. You cannot think of antiprotozoals the way you think of antibiotics. There is no broad spectrum here. There's no equivalent to penicillin.
No magic bullets.
None. A drug that kills an amoeba in the gut will do absolutely nothing against a leishmania hiding in the skin. Every organism is a distinct biological battle with its own unique set of rules.
Got it. Pillar 2.
Location dictates therapy. This is probably the most clinically relevant point of the entire deep dive. It is not enough to just know which drug kills the bug in a petri dish.
Right.
You have to ask, where is the bug hiding in the body? Is it floating in the gut lumen? Is it burrowed into the intestinal wall? Is it swimming in the blood? Or, and this is always the hardest one, is it hiding behind the blood-brain barrier?
Because if the drug can't commute to the job site, it can't do the work.
Precisely. Pillar 3 is metabolic targets. Since these guys are eukaryotes, like we said, we have to look for very subtle, very specific differences. We are hunting for unique enzymes, things with names like PFOR or trypanothione reductase, that humans either don't have or use in a very different way.
We're exploiting metabolic quirks.
Exactly. And the final pillar, pillar 4.
Let me guess. It's about safety.
It's the toxicity trade-off. Because the biological targets are so similar to our own, the therapeutic index, that window between cure and kill, is often terrifyingly narrow. We are going to discuss drugs where the side effects aren't just, nausea, but things like fatal brain inflammation or heart failure.
High-stakes poker.
Okay, so let's lay out the roadmap. We're going to take a kind of geographical tour of the human body to structure this. I like that.
We'll start in the intestine with the anaerobes. Then we'll briefly visit the reproductive tract. After that, things get heavy as we move to the blood and tissue for some of the major tropical diseases.
Okay.
And we'll wrap it all up with the opportunists that strike when the immune system is down.
From the uncomfortable to the lethal. Let's do it.
All right. Segment 1. The gut. The anaerobes. We have to start with Entamoeba histolytica. Now, I was looking at the epidemiology in Goodman and Gilman. It says 10% of the world is colonized. That seems incredibly high.
It is high, but there's a really significant nuance there that's come to light in recent years. We used to think anyone with an amoeba in their gut had histolytica.
Right.
But we now know through molecular testing that there are at least 3 species, E. histolytica, E. dispar, and E. moshkovsky, and they look identical under a standard microscope.
So you can't tell them apart just by looking.
You can't. But dispar and moshkovsky are generally peaceful squatters. They just hang out. Entamoeba histolytica is the aggressor.
Hence the name. Histotissue lytic destruction. It's a tissue destroyer.
Exactly. And even when you make that distinction, we are still looking at something like 50 million invasive cases a year and roughly 100,000 deaths. It's the 3rd leading cause of parasitic mortality worldwide, right behind malaria and schistosomiasis.
So to understand how we treat it, we have to understand its life cycle. The texts describe this organism as having a kind of Jekyll and Hyde personality.
It absolutely does. The Jekyll is the cyst. Think of the cyst as a tiny armored tank. It's biologically dormant, but it has this incredibly hard shell.
So it can survive in the environment.
It can survive in water, in soil. It can survive your stomach acid. You drink contaminated water, or you eat a salad that was washed in it, and you swallow this cyst.
The Trojan horse enters the gates.
Perfectly put. It travels down to the small intestine, and there, the change in pH triggers it to exist. It breaks open and it releases the hide.
The trophozoid.
The troph. This is the active, feeding, moving, dividing form. It's an amoeboid blob that moves around, eats bacteria, and if it's a histolytica species, it attacks the colon lining.
And that's where the clinical spectrum comes in.
Right. Most people are asymptomatic. The trophs just stay in the sludge, in the lumen. But if they decide to invade the mucosa, you get amoebic dysentery.
Which is not pleasant.
No. Bloody, mucus-filled diarrhea, abdominal pain. If you were to do a colonoscopy, you'd see these classic flask-shaped ulcers where they've burrowed into the wall.
And the worst-case scenario from there.
The worst case is they punch all the way through the colon wall, find a portal venule, and ride the portal vein straight to the liver.
Oh, wow.
And there they set up shop and form an amoebic liver abscess. This is a big, localized collection of, well, the classic description is anchovy paste pus.
Anchovy paste is a visual I could have lived without, but I will definitely remember it.
It's just necrotic liver tissue and a swarm of trophozoites. It's a serious, life-threatening condition.
Okay, so here's the clinical puzzle. I have a patient. They have dysentery. Or maybe a scan shows a liver abscess. I need to kill this thing. But the sources are very clear. One drug is not enough. We need a double tap.
This goes right back to that pillar. Location dictates therapy. We have 2 distinct locations we need to sanitize. The tissues, so the colon wall, the liver, and the lumen, the inside of the gut pipe itself.
So you have to treat both the invaders and the source population. Let's start with a tissue hit. What's the heavy artillery?
The gold standard here, and frankly for most of the anaerobic protozoa we'll talk about, is the nitroimidazole class, specifically metronidazole, which most people know as flagyl, or its slightly newer cousin, tinidazole.
Okay, flagyl, we use it all the time for anaerobic bacteria like Bacteroids or C. diff, but I want to really drill down on the mechanism. Goodman and Gilman gets very granular here. It says metronidazole is a prodrug.
Correct. When you swallow that pill, it's harmless, it's inert, it diffuses into all your cells and diffuses into the parasite. But absolutely nothing happens until it meets a very specific metabolic system.
And this is where that eukaryote difference comes into play.
This is the magic trick. Entamoeba is an anaerobe. It doesn't have mitochondria like we do. It relies on fermentation to make energy. And to do this, it uses a unique enzyme called PFOR.
PFOR. What's that stand for?
Pyruvate ferredoxin oxidoreductase. You don't need to memorize the name.
Okay, good.
Just think of PFOR as the parasite's unique anaerobic engine. And in the parasite, this engine generates high-energy electrons. Normally, those electrons go on to make ATP.
But metronidazole gets in the way.
Metronidazole is an electron thief. It has a very high affinity for these electrons. It steps in and steals one. Specifically, the nitro group on the drug is what accepts the electron.
And chemically, what does that do to the drug?
It transforms it from an inert molecule into a nitroradical anion. This is a highly reactive, incredibly unstable molecule. It's basically a grenade with the pin pulled. And it just starts smashing into everything nearby. It breaks DNA strands, it damages proteins, and activates critical enzymes. It just shatters the parasite's molecular machinery from the inside out.
So it's a suicide interaction. The parasite's own metabolism arms the weapon that kills it.
That is the perfect way to describe it. And here is the key to its safety in humans. We are aerobes. We don't have PFOR. And even if a tiny bit of the drug gets reduced in our cells by some other mechanism, oxygen is a better electron acceptor.
Okay.
Oxygen just swoops in and steals the electron right back from the drug before it can explode. It's a process called futile cycling. So in a well-oxygenated human cell, the grenade is a dud. The pin gets put right back in.
That is incredibly elegant. So evolution gave us oxygen as a built-in safety switch.
It did.
Okay, so the metronidazole gets absorbed, goes to the liver, goes to the colon wall, and it wipes out the trophozoites there. The patient feels better. Why aren't we done? What's the problem?
The problem is pharmacokinetics. Metronidazole is absorbed too well.
That's a strange problem to have. Usually we want 100% bioavailability.
We do, for systemic infections. You take the pill, it rushes out of the gut and into the blood. That's fantastic for treating the liver abscess. But it means the concentration of the drug back down in the fluid of the lower colon in the sludge drops to very low levels.
So the trophozoites that are invading the wall die. But the cysts and some trophs that are just floating in the middle of the pipe, they survive.
Exactly. And if you leave those cysts behind, two bad things can happen. One, the patient remains an asymptomatic carrier and can spread it to their family or community. Two, those cysts can exist later on and cause a relapse of the disease.
So you need step 2.
You need step 2, the luminal agent, the cleanup crew.
Okay, and what's the logic here?
For the luminal agent, we need a drug that is the exact opposite of metronidazole. We want a drug that is poorly absorbed. We want it to stay in the gut pipe and never make it into the bloodstream.
So what do we use?
The drug of choice in the U.S. is paramomycin.
Which is an aminoglycoside. It's in the same family as gentamicin or tobramycin.
Right. And we usually give those IV for serious gram-negative bacterial infections. But here, we give paramomycin orally, and since aminoglycosides are not absorbed through the gut wall at all, it stays right where we want it.
It's like a disinfectant for the inside of the colon.
It's exactly that. It acts like a sponge, soaking through the colon contents and killing off the remaining cysts and trophozoites that the metronidazole missed.
So the big clinical takeaway is, treating invasive amoebiasis is always a 2-drug regimen. A nitronidazole like metronidazole for the tissue, followed by a luminal agent like paramomycin for the gut.
Always. If you skip the second step, you have not finished the job. The patient is not cured.
Got it. And you mentioned there's another luminal agent.
Yes, the older drug is iodocanol. It's a halogenated hydroxyquinoline. It works, but it has some rare but serious side effects, including optic neuritis, and because of the iodine content, it can mess with your thyroid function. So paramycin is generally safer and preferred.
Okay, let's pivot slightly to a cousin of amoebiasis.
Giardia.
Giardia lamblia, or Giardia intestinalis, the backpacker's nightmare.
This is the most common intestinal parasite in the United States. You're out hiking, you drink from a pristine-looking mountain stream, and 2 weeks later...
Ugh. Explosive, foul-smelling, fatty diarrhea, steaturi. It's really distinct because Giardia coats the upper small intestine and physically blocks fat absorption.
So does the same double-tap logic apply here? Do we need a luminal agent for Giardia?
Surprisingly, no. Giardia is also an anaerobe, and it also uses that PFOR pathway we talked about. So metronidazole is the primary treatment, but for some reason, likely due to where Giardia lives higher up in the small intestine, versus amoeba in the colon, metronidazole alone is usually curative.
So the pharmacokinetics work out better.
They seem to. We typically do a 5 to 7 day course of metronidazole.
But looking at Katsung, it seems to make a strong argument for using tinidazole instead.
It does, and for a very good reason. Tinidazole is a second-generation nitromidazole. Its main advantage is a much, much longer half-life. And what does that mean clinically?
It means for giardiasis, the FDA-approved regimen is a single massive 2-gram dose.
One dose. Versus taking pills 3 times a day for a week, that's a massive win for compliance.
It's huge, especially if you're trying to treat kids. And the side effect profile is generally a bit cleaner, less nausea and GI upset than with metronidazole.
Let's talk about that side effect profile. Because whether it's metronidazole or tinidazole, there is one warning that you absolutely have to give every single patient: the alcohol warning.
The desulfurum-like reaction. This is classic board exam material, and it's also a classic emergency room presentation.
So what is the biochemistry here? Why does this happen?
Normally, your liver breaks down alcohol first into acetaldehyde, and then an enzyme called aldehyde dehydrogenase quickly breaks that acetaldehyde down into harmless acetate.
Okay.
Metronidazole inhibits that second enzyme. It blocks aldehyde dehydrogenase.
So the metabolic assembly line gets jammed, and acetaldehyde starts to build up.
Exactly. And acetaldehyde is a poison. It is the chemical that is largely responsible for hangovers, but now you're getting a massive concentrated dose of it.
What does that feel like for the patient?
If you drink a beer while on Flagyl, your acetaldehyde levels spike. You get intense flushing, a throbbing headache, violent nausea and vomiting, chest pain, palpitations. It feels like you are having a heart attack.
It's basically a Clockwork Orange-style aversion therapy for drinking.
It is, and it's important to tell patients it can happen even with the small amounts of alcohol and mouthwash or some cough syrups.
Right.
You have to be really strict. No alcohol during treatment and for at least 72 hours after the last dose to give the enzyme time to recover.
That is a critical pearl. Okay, one more organism in this group before we leave the anaerobes. Trichomonas.
Trichomonas vaginalis, the most common non-viral STD in the world.
So clinically, how does this differ from Giardia and amoeba in terms of its biology?
The key biological difference is that it has no cyst form. It's strictly a trophozoite. It can't survive in the environment. It transmits via direct mucosal contact. So,
Sex,
which makes sense, right? It doesn't need a hard shell to survive a mountain stream or a salad bar.
and a treatment.
Very straightforward. Metronidazole or tinidazole. Again, tinidazole is often preferred because of the single-dose option. But there is a crucial clinical rule here that is unique to STDs, and it's something you can't forget.
The partner rule.
You cannot just treat the patient sitting in front of you. It's not enough. If you cure the patient and they go home to an untreated partner, they will be reinfected by the weekend. We call it the ping-pong effect.
So you have to break the cycle.
You must treat all sexual partners simultaneously, even if they are asymptomatic. And it's important to know that men are almost always asymptomatic carriers of trichomonas.
So treating trichomonas is really a public health intervention, not just a patient intervention.
Absolutely. It takes a village, or at least a couple, to clear trichomonas.
Okay, let's pack our bags. We're leaving the relatively familiar territory of the U.S. and the gut behind. We are getting on a plane to sub-Saharan Africa. We are entering the world of the kinetoplastids and African sleeping sickness.
And this is where the story gets much, much darker. We're talking about human African trypanosomiasis, caused by Trypanosoma brucei.
Transmitted by the tsetse fly. I feel like we all learned that name in grade school. But the pharmacology here is just fascinatingly complex, not just because of the bug, but because of the anatomy involved.
Right. And first, we have to distinguish the two subspecies. There's West African sleeping sickness, caused by T. brucei gambiense, and East African, caused by T. brucei rhodesian.
And the simple way to remember it is west is slow, east is fast.
Broadly, yes. That's a good way to think about it. The West African form is a slow burn. It can simmer for months, sometimes years. The East African form is a wildfire. It's acute. It has a rapid progression, and it often kills the patient via cardiac failure before the brain even gets fully involved.
But for both of them, the entire treatment protocol relies completely on staging.
Staging is everything. There's no way around it. You have to do a lumbar puncture. You have to look at the cerebrospinal fluid.
All right. What are you looking for?
We need to know one thing. Has the parasite crossed the blood-brain barrier? Stage 1 is the hemolymphatic stage. The bug is in the blood and the lymph nodes. Stage 2 is the meningoencephalitic stage. The bug is in the brain.
And looking at the drug list in Katsung, the reason for that becomes crystal clear. The stage 1 drugs don't cross the barrier.
They don't. For stage 1 West African disease, we use a drug called pentamidine. For stage 1 East African, we use suramin. These are large, charged molecules. They are fantastic at killing parasites in the bloodstream, but they bounce right off the blood-brain barrier.
So if you have a patient with bugs in their brain and you give them
You cure their blood and they die of encephalitis, you have to get the staging right.
So if that spinal tap is positive, if there are trypanosomes in the CSF, we need drugs that can penetrate the CNS.
And this brings us to, well, to one of the most frightening therapeutics in all of modern medicine, Malarsaprol. Malarsaprol. Just the name itself sounds heavy, doesn't it? This is an arsenic compound.
Wait, say that again? We are literally injecting arsenic into people.
We are. It's a trivalent arsenical. And it's so toxic and so insoluble that it has to be dissolved in propylene glycol.
Which is antifreeze.
Yes. It's a component of antifreeze. When you inject it, it is incredibly caustic. It burns the veins. It can actually destroy the plastic tubing of infusion sets if you aren't careful. It's a punishing drug to administer.
Why on earth are we still using this? This feels like medicine from 1850, not the 21st century.
Because for a very long time, for the advanced CNS stage of the East African form, it was the only thing that worked. It was a choice between certain death from the parasite or taking a gamble with the poison.
So how does it kill the parasite? What's the mechanism?
It targets the Achilles heel of the trypanosome, a molecule called trypanophyllum.
Okay, that's a new one.
We mentioned earlier that these parasites have unique metabolic targets. So human cells use a molecule called glutathione to handle oxidative stress. Trypanosomes don't use that. They use a unique conjugate of glutathione and spermidine called trypanothione.
So it's a completely different antioxidant system.
Right. And Malarsaprol avidly binds to the sulfhydryl groups on this molecule and the enzyme that reduces it. It essentially shuts down the parasite's ability to handle oxygen radicals. The parasite just oxidizes to death from the inside.
But arsenic is a poison. It binds sulfhydryl groups in human enzymes too.
It does. It's a dirty drug. It's not perfectly selective. It reacts with human enzymes, though with slightly less affinity. But the side effect profile is... it's a nightmare. The most feared complication is reactive encephalopathy.
Which sounds like the exact opposite of what we want to happen.
It is. It's a massive, acute inflammatory storm in the brain, triggered by the drug and the dying parasites. It happens in about 5 to 10% of patients treated with Malarsaprol.
And what's the outcome of that?
The mortality of that specific complication is about 50%.
I need you to pause on that. We are giving a drug that, in 1 out of every 10 patients, causes a brain problem that kills them half the time. So we are giving a drug that kills 1 in 20 patients.
We are. It's a terrible, terrible calculus. But untreated stage 2 sleeping sickness is 100% fatal. So you risk the 5% mortality from the drug to avoid the 100% mortality from the disease. That is the grim math of Malarsaprol.
Unbelievable. However, for the West African form, the Gambiense type, we have a much better story. A story of redemption almost. The resurrection drug. Eflornithine.
I love the story of eflornithine. It's a complete triumph of scientific serendipity. It was originally designed as a cancer drug.
And it didn't work?
It failed. It just didn't stop tumor growth well enough. Then someone noticed it stopped hair growth, so it was repurposed and marketed as Vanica, a facial cream to prevent unwanted hair in women.
So it went from a failed cancer drug to a cosmetic cream.
Exactly. But while all that was happening, researchers realized its mechanism of action was perfect for trypanosomes. It is a suicide inhibitor of an enzyme called ornithine decarboxylase, or ODC.
Okay, break down ODC for us. What does it do?
ODC is the rate-limiting step in making polyamines. Polyamines are these small, positively charged molecules that are essential for stabilizing DNA and for cell division. If you run out of polyamines, you cannot divide. Your cells just stop.
Okay, but humans need to divide cells too. We have ODC.
Right.
So why doesn't eflornithine kill us?
This is the magic of enzyme turnover. Eflornithine binds irreversibly to ODC. It can use the enzyme molecule. It takes it out of commission forever.
Right.
Now, a human cell says, oh, my ODC is broken, no problem, I'll just make more. Our cells have a very rapid turnover of this enzyme. We can replenish our supply in minutes to hours.
And the parasite?
The parasite has incredibly slow turnover. Once you knock out its ODC, it takes days to make more. And in that time, it starves of polyamines. It goes into a state of suspended animation and eventually gets cleared by the immune system or just dies.
Hence, resurrection. You can have a patient in a coma, on death's door from sleeping sickness, and eflornithine can literally bring them back.
It's remarkable, and it's much, much safer than Malarsaprol. The big problem for years was the regimen. It used to require 14 straight days of IV infusions, 4 times a day.
Logistically impossible in rural Africa.
Absolutely. You need huge amounts of sterile fluid, tubing, 24-hour nursing care. It was just too difficult.
But Ketson mentions a new protocol, NATI.
Yes. Nifurtimox eflornithine combination therapy. A breakthrough. Researchers combined eflornithine with nifurtimox, which is another antiprotozoal we'll discuss. This synergy allowed them to cut the treatment down to 7 days and reduce the number of infusions dramatically.
Making it actually usable in the field.
Exactly. It's now the standard of care for West African CNS disease. It has saved thousands of lives and has dramatically reduced the reliance on the arsenic option.
That is a genuine, unqualified win for pharmacology. A great story. Okay, now let's cross the Atlantic. We're going to South and Central America, Chagas disease.
American trypanosomiasis, caused by Trypanosoma cruzi.
The vector here is different. It's the triatamine bug,
Yep.
famously known as the kissing bug.
It's called that because it tends to bite you on the face at night while you're sleeping. And in a really disgusting twist, it doesn't inject the parasite with the bite.
So how do you get infected?
It bites you,
Yeah.
and then it defecates right next to the wound. The feces are full of parasites. You're asleep, the bite itches, you scratch it, and you rub the infected feces into your own bloodstream or your eye.
That is just,
That's
it's a fecal-oral blood route, all in one. Now, the clinical timeline here is very different from African sleeping sickness. It's not about blood versus brain. It's about acute versus chronic.
That's the whole story of Chagas.
Yeah.
The acute phase lasts for a few weeks right after infection. You might have a fever, some swelling, maybe a swollen eye, which is called Romagn's sign. The parasites are swimming around in your blood at high levels.
And then they disappear.
They seem to. They invade the tissues, specifically the heart muscle and the smooth muscle of the gastrointestinal tract.
And they just sit there for
With it.
decades.
For 10, 20, even 30 years, silently creating this low-grade chronic inflammation. And eventually, the heart muscle gets destroyed and replaced by fibrosis. The heart walls get thin and flabby. You get dilated cardiomyopathy and heart failure.
And in the gut.
The nerves that control peristalsis get destroyed. This leads to megaesophagus. The esophagus gets huge and can't swallow properly. And megacolon.
The mega syndromes. So treating Chagas depends entirely on when you catch it.
It has to be early. We have 2 drugs, benznidazole and nifurtimox. Benznidazole is the first line pretty much everywhere now.
What's the mechanism?
It's very similar to metronidazole. It undergoes reductive activation inside the parasite and generates radical species that damage DNA and proteins. It's another one of those molecular bombs.
And how well does it work?
If you catch the patient in the acute phase, in those first few months after infection, it's curative. You get 80 to 90% cure rates.
But that's the problem, right?
That's the whole problem. Most people don't go to the doctor for a bug bite and a mild fever in rural South America. They show up 20 years later with heart failure.
And does benznidazole work then in that chronic phase?
This is the heartbreaking part of the story. The BENEFIT trial, a major clinical trial that's cited in the texts, looked at this exact question. They gave benznidazole to patients with established Chagas cardiomyopathy.
And what did they find?
They found that the drug reduced the number of parasites in the blood, but it did not stop the heart disease from progressing. It didn't reduce mortality. It didn't improve clinical
The
outcomes.
horse has already left the barn.
That's the perfect way to put it. By the time the heart is failing, the damage is likely driven by autoimmune mechanisms or irreversible fibrosis. Killing the few remaining parasites doesn't fix a scarred, broken heart.
Which just emphasizes why screening and early detection in endemic areas is so incredibly critical.
It's the only way to win.
Okay, let's move to our next stop on this tour. The intracellular hider. We're talking about leishmaniasis.
Leishmania, transmitted by the bite of a tiny sandfly. This organism is a master of disguise and evasion.
We keep coming back to location dictates therapy. Where does leishmania hide?
It does something incredibly bold. It gets eaten by a macrophage. Now, you have to remember, the macrophage is the immune system's tank. It's a professional killer. Its job is to swallow invaders and digest them in a bag of acid and enzymes called the phagolysosome.
But leishmania is okay with that.
It loves it in there. It's evolved to thrive in that hostile environment. It changes the surface coat of its lipophosphatoglycan to resist the enzymes. It thrives in the acidic pH. It essentially turns the killing machine into a safe, comfortable condo.
So it's hiding in plain sight, inside the very cell that's supposed to kill it.
And it replicates inside the phagolysosome. Clinically, this manifests in 3 main ways.
What are they?
There's cutaneous leishmaniasis, which causes these ugly chronic skin ulcers, sometimes called the Baghdad boil. There's mucocutaneous, which is horrific. It eats away the cartilage of the nose and mouth, causing terrible disfigurement. That's called espundia.
And the most serious form.
Visceral leishmaniasis, or Kala-Azar. The infected macrophages migrate to the liver, spleen, and bone marrow. The spleen becomes massive. The bone marrow fails, leading to pancytopenia. It is uniformly fatal if left untreated.
So how in the world do we kill a bug that is hiding inside the lysosome of a macrophage?
For about 70 years, we used pentavalent antimonials. The main drug was sodium stebogluconate.
So we are back to the heavy metals. Antimony is right below arsenic on the periodic table.
And it behaves a lot like it. It's a prodrug that gets reduced to trivalent antimony, and it's thought to inhibit the trypanosomiasis system again. But the toxicity is rough.
What kind of side effects?
Pancreatitis, excruciating muscle and joint pain, and cardiac arrhythmias, specifically QT prolongation, which can lead to torsades de pointe. And on top of all that, it requires 28 straight days of IV or IM injections.
Not ideal for a field clinic in Sudan or Bihar, India, but there is a huge breakthrough mentioned in the text. Miltefosine.
Miltefosine is a true game changer for one simple reason. It is oral, no needles.
That's huge.
Yeah.
How does it work?
It's another one of those failed cancer drugs that found a new life. It's a phospholipid analog. It basically gets incorporated into the parasite's cell membrane and messes up lipid metabolism and cell signaling pathways. It seems to trigger apoptosis or programmed cell death in the parasite.
An oral treatment sounds perfect. What's the catch? There's always a catch.
The catch is a big one. It is highly teratogenic. It causes severe birth defects.
That is a massive limitation in its use.
It is. You cannot give it to pregnant women, period. And because the drug has a super long half-life, it stays in the body for months. So a woman of childbearing age needs to be on strict, reliable contraception during treatment, and for roughly 4 to 5 months after finishing the course.
That's a huge counseling point.
Yeah.
I also want to touch on amphotericin B. We usually think of amphotericin for serious fungal infections.
Right. It's a heavy hitter antifungal. But the liposomal formulation of amphotericin is actually the FDA-approved first-line treatment for visceral leishmaniasis in the U.S.
Why does an antifungal work so well here?
For two brilliant reasons. One, leishmania cell membranes contain ergosterol, just like fungi do, not cholesterol like human cells. So amphotericin can punch holes in their membranes specifically.
Okay, so there's a selective target.
But the second reason is even cooler. The liposomal formulation puts the drug inside these tiny little fat bubbles.
The Trojan horse again. I'm sensing a theme.
It is. Macrophages are professional garbage collectors. They are programmed to eat fat particles. So when you infuse liposomal amphotericin, the infected macrophages just gorge on it. They inadvertently deliver a massive concentrated dose of the poison directly to the parasite that's sitting inside their belly.
It's targeted delivery by hijacking the host's own cleanup crew.
It's one of the most elegant examples of targeted drug delivery in all of medicine.
That is brilliant. Okay, we are in the home stretch now. We've covered the anaerobes and the tropical vectors. Now we turn to the opportunists. We're talking about toxoplasmosis and cryptosporidiosis.
The theme here shifts a little bit. These aren't necessarily exotic infections you have to travel to get. In fact, a huge portion of the listeners right now probably have toxoplasmosis in their brain.
Wait, don't panic the audience. Explain that.
It's true. If you have a healthy immune system, Toxoplasma gondii is almost always harmless. You might get it from eating undercooked meat or from cleaning a cat litter box. Your immune system fights it off and then walls it off into these tiny, dormant cysts. You never even know you have it.
But if you get HIV/AIDS or you're a transplant patient on immunosuppressants,
the walls come down, the cysts reactivate, and the parasites start dividing again. And they have a predilection for the brain, causing toxoplasmic encephalitis. You see these classic ring-enhancing lesions on an MRI scan.
So how do we treat this reactivation?
We go after a classic antimicrobial target, folate metabolism. This is the exact same strategy we use for bacteria with the drug Bactrim or trimethoprim sulfa. We need to block the parasite's ability to synthesize the building blocks for its DNA.
And for toxo, the drug combination is different.
The synergistic combo is pyrimethamine plus sulfadazine.
Why do you need two drugs?
It's all about synergy. You get an effect that's much greater than the sum of the parts. 1 + 1 = 10. Sulfadazine blocks the first enzyme in the pathway, dihydropteroate synthase. Pyrimethamine blocks the next enzyme in the pathway, dihydrofolate reductase, or DHFR.
So by hitting two consecutive steps in the same supply chain, you crash the whole system.
You shut down folate production completely, but there's a snag.
What is it?
Humans have DHFR too. We need folate to make our blood cells in the bone marrow. And pyrimethamine doesn't know the difference between the parasite's enzyme and ours, so it causes significant bone marrow suppression, anemia, leukopenia, thrombocytopenia.
So how do we get around that?
We have to provide a rescue. We give the patient folinic acid, which is also called leucovorin.
Explain the rescue. Why doesn't the leucovorin just feed the parasite and cancel out the drug's effect?
This is the really cool part. Leucovorin is a preformed activated folate derivative. Human cells have a specific transport pump that actively pulls leucovorin inside, completely bypassing the DHFR block.
And the parasite doesn't have that pump.
Toxoplasma lacks that specific transporter. It can't import the rescue. It has to synthesize all its folate from scratch, which is the very pathway we have blocked.
So we poison the well for everyone, but we give the humans a secret supply of bottled water.
That is the perfect analogy.
Okay, last bug. Cryptosporidium.
The scourge of the AIDS epidemic in the 1980s and 90s. Before we had good antiretrovirals, this parasite caused a massive, unrelenting, liters per day watery diarrhea that would literally waste patients away.
And the drug listed for it is nitazoxanide.
Which works by, you can probably guess by now, interfering with the PFOR electron transfer reaction, just like the nitromidazoles, but it's a slightly different chemical structure.
And it works well in healthy kids who pick up crypto at a swimming pool or a water park. But what about the AIDS patients it was so devastating for?
It's disappointing. In patients with very low CD4 counts, nitazoxanide barely touches the infection. It might reduce the stool volume a little, but it's not curative.
So what is the real treatment then?
The real treatment is HART, highly active antiretroviral therapy. You have to treat the HIV. You have to get the CD4 T cell count back up. Once the immune system comes back online, it clears the parasite itself.
So the drug is supportive, but the cure is immune reconstitution.
No antiparasitic drug is as powerful as a functional T cell.
That is a really powerful place to land. Sometimes the best antiparasitic is actually an antiviral that restores the host's own defenses.
Absolutely.
So looking back at this entire deep dive, we've covered a lot of ground, a lot of different organisms and drugs. What is the synthesis? What's the big picture?
I think the synthesis is that we are in a constant arms race with these organisms and we are holding the line, but it's messy. It's not clean. We don't have the clean kills that we often have in bacteriology. We are relying on redox active radical generators like metronidazole that act like molecular grenades. Heavy metals like arsenic and antimony that are basically just controlled poisons. And metabolic inhibitors like eflornithine and pyrimethamine that try to selectively starve the bug before they starve the host.
And for the clinicians listening, it really reinforces that the patient's history is your most powerful diagnostic tool. Where have you been? Points you towards the trypanosomes and leishmania.
What is your immune status? Points you to toxo and crypto.
Who is your partner? Points you directly to trichomonas.
And are you pregnant? Changes the entire risk-benefit calculation for treatment because of the teratogenicity of drugs like miltefosine and the high-dose antimetabolites.
I want to leave the listener with a final provocative thought. We talked about how similar these eukaryotes are to us, and we know that resistance is rising for these drugs, just like it is for antibiotics. Are we going to be stuck using arsenic and antimony in the year 2050?
I really hope not. The future has to be in precision medicine. We need to move past these crude tools. We need to be exploiting those tiny, subtle differences, like the exact crystal structure of the trypanothionein reductase or the specific protein kinases that leishmania uses for signaling to design small molecules that fit only into the parasite's machinery.
So moving from shotgun blasts to sniper shots.
That is the entire challenge, and it's the challenge for the next generation of pharmacologists, maybe even for some of the people listening to this right now.
A challenge I hope someone listening will take up. For all the dosage details, the renal adjustments, the specific side effect profiles, and the pediatric considerations, go read Katzung's chapter on antiprotozoal drugs.
And if you really want to geek out on the electron transport chains of anaerobes or the intricacies of the trypanothione redox systems, Goodman and Gilman's chapter on the chemotherapy of protozoal infections is waiting for you.
Thanks for diving deep with us today. Stay curious, wash your hands, and maybe filter your water.
Take care, everyone.